So I'm going to be talking about postpartum hemorrhage. A moderate postpartum hemorrhage is considered 500, and severe is considered 1,000 or over. But everybody's different. So if a person is having these symptoms of shock with, like let's say 500 or even less than that, then that's something that we have to consider and be proactive in that case. It's important to be evaluating how much blood is being lost by looking at making sure that the blood isn't pulling back, changing out chest pads frequently, and getting an overall assessment of how much blood is being lost. Um, okay, so I'm going to move on to the different types of categories. So there's tone, trauma, tissue, and thrombone. Uterine fatigue could cause a postpartum hemorrhage, and that is usually due to a tired uterus that has had a long labor and is just not effective or being effective with contractions to help stop the bleeding. A retained placenta could be a reason, or just tissue fragments or uh, retained parts of the placenta. So if the placenta is out, it's important to get a visual of the placenta to make sure that it is intact. And um, if the placenta is not out, it's important to get the placenta out. Significant lacerations could cause bleeding, and so this is a good reason to get a visual of just trying to determine if you see anything that could be the cause of bleeding. So if you see a laceration, then you know where to focus. And a coagulation disorder is another reason why you could have a postpartum hemorrhage. And a coagulation disorder could be determined if we're seeing that blood is not coagulating. And if so, if blood is dripping on the floor or has fallen on the floor and it's not coagulated, then that's something that we're not going to wait to call EMS. If we notice that early on, then we're going to call EMS before we even try to attempt to manage. Well, we're still going to manage, try to do everything in our power to control the situation, but we're not going to be waiting if we see that coagulation happening. So our clients with postpartum hemorrhage may be feeling different symptoms. They could be feeling dizzy, lightheaded. They could have pain due to the laceration. They could have a rising uterus or like a boggy uterus. So assessing where that, like the how's that feeling and how's that looking is a good idea. You also want to, they also may be showing signs of shock. They may be sweaty, clammy, non-responsive, or fainting. They could be showing rising pulse, shallow aspirations, or as, and low blood pressure. Um, if we're seeing those signs of shock, then I would want to be calling EMS, even if we haven't gotten to um, treating it. Like, I'm not going to wait. So, we're going to start doing our medicine, but we're not going to wait on that if we're seeing signs of shock. So, I could provide O2, I could position the legs up. I could make sure that the client has like warmth. I could have at this point got an IV in my client, um, and I could just make sure that the client is responsive, talking to my client, asking my client to talk to their baby. This is something that I want to be aware of. And so I wanted my assistant to be assessing vitals frequently and keeping an eye on the pulse, temperature, respirations, blood pressure of my client. Okay, so like I said, if the placenta is not out, that's going to be my first focus. So we want to make sure that we're getting that placenta out if we are having a hemorrhage. So I could do that by manually removing it, but I'm first going to assess if I see that it's detached, because that could help determine how I'm going to take out this placenta. So if I've seen that there was a like a separation gush, if I see that the cord has lengthened, there's also a maneuver called the modified Brandt-Andrews maneuver that we talked about in our live session to help us determine if the placenta has separated. Those are good things to use. If we determine that the placenta is not separated and there is a hemorrhage, then I would administer Pitocin 10 IM in, um, and I would put on sterile gloves and go in and go all the way back and try to do the scooping of the placenta off of the uterine wall manually. I will be talking to my client, letting them know what's happening. This is going to be a painful procedure, so I'm going to be making sure that I'm telling the client, like, I know this is uncomfortable. I'm trying to help, like, just keeping that informed like consent conversation like open, just explaining what I'm doing while I'm doing it, right? And so that's something that I could do if I'm feeling like that the placenta is just stuck onto that wall. I'm not going to continue to try to take it out. I'm going to make sure that I'm getting EMS on the way at this point. So let's say that the placenta is out. I'm going to examine it, making sure that it's all intact. And if there's not, then I could manually like do a manual exploration to see if there's any like fragments um, left. And yeah, so let's go into medicine. So I am more comfortable with going straight into using medication rather than the herbs prior to the medication if there's a hemorrhage going on. If it was just a placenta that's taking a little longer with no bleeding, then I would definitely reach for my herbs first. But in this case, oxytocin would be my first line of medicine. So as I said, I would have 10 ml of oxytocin done in the thigh, and I would make sure that the client, I'm talking through what's happening. This is something that my assistant could help me with, or and I could do up to 4 of those, but I would do 2 prior to doing 4. If those 2 are not working and I'm not seeing a reaction to the medication, like I'm not seeing improvements with the medication, I'm going to be calling EMS at that point before moving on to my next. And by I'm going to call it, meaning I'm going to have my assistant call so I could continue to work on helping this client. So after that, I would go to Metrogyl, and that's a 0.2 mg, also intramuscular. If that's not working, my next medicine would be misoprostol. That's something that I'd give like orally, and 600 is what I would give. I don't know much about TXA, but I know that we are allowed to use that now, and that's done via IV. And so at this point, I would already have an IV placed in my client, and I would administer it that way. I would also, if the hemorrhage is not responding to medication, then I'm going to use some manual maneuvers. So I could do like the internal like compression where I have one hand on the uterus and the other internally and putting pressure that way. I'm having a brain bimanual compression. And then I could also do where I feel for the artery and the aortic compression. That is something that is like last line if like the medications aren't working. I I'm going to be having my assistant call if there's signs or symptoms of shock, if this hemorrhage is not reacting to my medication, if my if I suspect like a retained fragments or like a retained placenta, and if I'm going to need a repair. So if it's due to a laceration that is beyond my scope, that's something that I will transfer for. I believe that is it. I feel like I'm forgetting everything, but